Perfect. Welcome everybody who is just hopping on. All lines are muted upon entry, so we will go ahead and get things started. So hello everyone and welcome to the Foundation Fighting Blindness quarterly chapter vision webinar. My name is Bailey Bostelman. I'm the regional field director for the East here at the Foundation. We are so excited for you to be here sharing your Saturday with us. I'd like to briefly just review some logistical details for the call. Currently, all participant lines are muted. Today's call is being recorded and will be shared with all registrants after the meeting concludes in the coming week. You will also be able to find the recording on the Foundation Fighting Blindness website within the coming days as well. If you are using a screen reader, please be aware the controls are at the bottom of the Zoom interface. This control bar may collapse when not in use, so make sure to jiggle your mouse before clicking anything. If you prefer to prevent the controls from auto-hiding, go to your settings within the Zoom platform, select Accessibility, and then select Always Show Meeting Controls. If you have any questions throughout the presentation, please send them using the Q&A function within Zoom. Today, our expert panelists will cover the topic of how to speak to your eye care professional. After the introductions, we will open up the floor for Q&A from our panelists. Whether you're a patient, a caregiver, or healthcare professional, we hope this webinar provides valuable insights. Now, I'm pleased to hand it over to our moderator for today's discussion, Chad Jackson, who's the Senior Director of Preclinical Translational Research Program at the Foundation. Chad, thanks for joining us today.
Oh, I'm honored to be here, and thank you, Bailey, for that introduction. And first and foremost, I want to really, again, thank everybody for taking time out of their Saturday to join this webinar. I know that it's going to be very fruitful and provide maybe some very tangible information that people can take back and use in their day-to-day lives. So I appreciate everyone being here. First, I'll reintroduce myself again, just to make sure everybody knows. My name is Chad Jackson. I'm the Senior Director of the Preclinical Translational Program at the Foundation Fighting Blindness. And I've been with the Foundation, it'll be 6 years and 3 days. So I'm so stoked about what the Foundation is up to and just really happy to be a part of this webinar. And if there's anyone sort of new to the Foundation, I just want to restate our mission. And that the mission of the Foundation is to drive the research toward the prevention, treatments, and cures for blinding retinal disease. And that's what we are squarely focused on our day-to-day. But a part of us meeting our mission is make sure we have an informed patient and patient advocate population. And that's sort of the root at which why we are having this current webinar. So it is now my honor to introduce our panelists for the webinar. So first I'll introduce Brenda Nikko, who is the chapter president of the Foundation for the Fort Wayne chapter and an active research participant for retinitis pigmentosa. Brenda brings a valuable perspective from both an advocacy and clinical trial participant standpoint. Next, I introduce Dr. Safa Rahmani, a board-certified ophthalmologist specializing in pediatric retinal disease and inherited retinal degenerations. Dr. Rahmani was a leader in the first U.S.-approved gene therapy for LCA, which was Luxturna, and serves as a retinal specialist at the Ann Robert H. Lurie Children's Hospital of Chicago. Today, what you will learn, hopefully, and we'll almost try to guarantee it, are key questions to ask the ophthalmologist or retinal specialist, tips for effective communication tips regarding symptoms, family history, and treatment goals, understanding the importance of genetic testing and how to discuss the results, and strategies for staying informed about clinical trials and new therapies. So again, the chat function is open, so please ask away. We have plenty of time to try to field as many questions as possible. So with that being said, I'd like to turn the floor over to maybe starting with you, Dr. Rahmani, to speak to the physician standpoint on how a patient, how they can actually help a patient. So giving your standpoint as a physician.
That sounds great. I'm going to share my screen if that's possible. Are you guys able to see my screen? Well,
Yes, and if you could please put, yeah, fine. You are good to go.
excellent. So thank you, Chad, for the introductions. I'm Safa Rahmani. I'm based in Chicago, and I take care of kids and adults with inherited retinal diseases. I'm also a retinal surgeon, so I do see regular retinal patients as well. So this is my passion and interest. So I'm very honored to be here today. So, I think this is a great talk to kind of start, like, how do I need to tell my doctor what's going on? And I really think it starts with your story, like, what are your concerns? Tell me what is most bothering you. Is it I can't read, or there's something going on at night, or I'm bumping into things, when did the symptoms begin? How are they changing? Are there any patterns? Because there'll be patterns where, oh my goodness, I'm struggling in the sunlight, or I'm struggling in cloudy days. Those are very important. And why does this matter? It's because these details really narrow down what inherited conditions may be involved and really determining the urgency, testing, and next steps for us. Share your family history. I can't tell you how important this is, even small clues. Anyone in your family, they'll be like, oh, cousin so-and-so had unknown vision loss. What happened? And again, when you go further back, there may be absolutely no diagnosis, but that, somebody in the family was struggling with vision. Are there family members that can't see at night? Are there color issues? Was somebody determined to be legally blind? And then there are different regions have different concerns in terms of what can run in their family. So this is important because the inherited conditions really show patterns across generations. So this really helps us choose the right genetic tests and counsel you more appropriately. I can't stress this enough. Bring prior testing or imaging, especially when you first start to have symptoms. It's very common for people to see multiple specialists before something is figured out. And really, if there's any genetic testings, any pictures, any information that you have from previous eye care professionals, it really helps because it gives us a sense of how fast things are moving. It gives us a longitudinal interpretation, and old test again gives us, and a lot of times we may not even need to do some of the tests for you because you've already had it done. This is important because this is not just with your eye care professional, but this is really with your whole eye care team. Discuss your lifestyle, vision needs, and daily challenges. What is it that makes it difficult for you on a daily basis? Do you need work accommodations? Do you need, what is it, the issues with driving? Are there emotional, psychological concerns? Especially in kids and parents, those are different dynamics that really come into play. Do you need low vision rehab, mobility training? All this comes into play because inherited diseases really impacts daily life. It's not just, oh, let me take an retinal imaging and we're done. We want to support you through the functional vision, independence, quality of life, not just this is your diagnosis, have a good day. And then ask about genetic testing and what the results mean. Some people are very comfortable getting genetic testing. Others are a little bit more concerned. I tell them genetic testing is one of the most powerful tools we have because it helps us give some idea of prognosis. It allows us to see if you're eligible for any clinical trials or treatments. It helps with family planning significantly. And sometimes it really helps with surveillance of other systemic associations if you have an eye issue that will eventually can lead to other issues in the body. So I think these are very important questions to ask your eye care provider. And then ask about current emerging therapies. This is what Foundation Fighting Blindness does. Ask us about what's going on because it allows us to know how interested you are. Some people are really interested in early clinical trials. Some people are interested in waiting out. And again, everyone's needs are different. So we want to know where you are and what you're thinking about because that gives us time to kind of provide resources for you and give you realistic timelines. And ask about monitoring and resources. Again, this is what Foundation Flying is one of the resources that they have are these kind of webinars and these things, like when do I need to see you, how frequently will follow up, and share the resources. And a lot of us in this field have a lot of resources to share between all of us. And then what your physician really wants to know, what I want you to know is like, you're not alone. We are here to walk this journey with you. Even when no cure exists, there's always something we can do, which is really important. We can optimize the vision, manage the complications, monitor progressions, connect you to, support groups and trials, and really support what you want to do in your life. And the field, as you all know, is rapidly advancing. So what may be not an option today, within a few years, may be a complete option. So I have hope. And this is my personal approach when I first see any patients that I have a suspicion of an inheritable disease. I really try to discuss what's going on with their vision. The questions that I think is always foremost, am I going to go blind? I'm going to try to address that right away. What can I do to prevent vision loss? I try to address that at every visit. And then are there any therapies? So when I first meet a patient for the first time, these are really the things that I want to hit because I know it goes through everyone's mind. Sometimes more, sometimes less. And again, we come back to these questions as the workup goes. And as you guys know, sometimes it takes a while to get any diagnosis, and it can be very, very challenging. Thank you.
Dr. Rahmani, thank you so much for that presentation. I think actually we have the benefit of running a little bit ahead of time. And so I think that maybe we can pause here and take a few questions. We do have one that's currently already populated, so I'll just read it as it has been submitted. This question is, I have been told twice that I'm not blind enough, in quotes, to be part of 2 different studies. As I only have 10% field left, I don't understand. I was diagnosed at 62. Should children be tested? So I think out of that question, there's probably 2 things. Could you give a little bit more insight into sort of the inclusion criteria of clinical trials for people with low vision? And could you also, if someone has been diagnosed, could you give their advice about if their children should be tested or not?
Those are 2 great questions, and it can go into 2 very different discussions. So the first thing is in the eye world, blindness is really carefully used. The word blind is, for us as the providers, is no lights, no nothing, no vision. So I want to kind of clarify that when somebody says you're not going blind, the chance of blindness where there's no lights, no vision is very low for the majority of the diseases. This does not mean that you don't struggle and have issues, because you can have tunnel vision, as a lot of our RP patients know, and you can have issues where you don't see centrally with our Stargardt's patients, but you have good side vision. Those are all very important things, and the states have decided what's considered legal blindness and what's not, because at some point these can really affect the functionality of what you can do on a daily basis, including driving, reading, those kind of things. So I think it's very clear, and I make it clear to my patients, when I say blind, I mean lights out, nothing. And thankfully, majority of our patients don't go through that. The other thing is, when you're diagnosed much earlier versus much later, the tempo can be very different. So when a kid is diagnosed at very young, they have a lot of time to sort of adjust to the changes that come with time. Whereas when we're adults are diagnosed, it's much harder because they already know what kind of vision they were able to do and what they were able to do, and to kind of get adjusted to the loss can be much more difficult. So those are all nuances that can go into, what does it mean that they're telling me I'm not blind or I am blind? So when they say you have 10% of your vision left, it probably means, the central vision, but you have all this important side vision that helps you navigate your world, and you don't have that. So yes, and you are not blind, but you have many issues that could go into how you function on a daily basis. But I think kind of figuring out what your eye care professionals, what kind of vocabulary they're using when they use the word blind, or when they use vision loss, or when they use, legal blindness, those are all can be very different. So I think clarifying that with your provider can be very helpful. The second question really comes down to the specific disease and the nuances of what the genetic testing shows. Because if the gene is known to kind of run in a certain patterns, it's more helpful to test families versus the way that the genes are, and it was a new mutation in that particular patient. So these can be very nuanced, and this is when our genetic counselors can become very helpful, because they can really dig into the weeds and decide, is it worth testing other family members, and is it worth testing children? I've had a lot of patients whose kids have been tested, or they do testing to see, when they want to have family planning, do they want to be able to find that gene or not to pass it on to other kids? So all those are very nuanced, and I don't think you can say, oh, this is what we do for everybody, because it's really patient dependent. It's very gene dependent, and it's very disease dependent.
All right, thank you for that. And for the audience, I do want to also mention that if you have seen a retinal specialist and you have been diagnosed with an inherited retinal disease, you can receive free genetic testing through the FFB's genetic testing program, which also affords you access to a genetic counselor that can help go through more details about your particular disease. So I just wanted to mention that there is a way for to get genetically tested completely free through the Foundation Fighting Blindness. We have one more question. I think we have time for one more before we move on. And so I'll just read it again as it was submitted. It says, "Hi, I am very lucky to be seen a globally acclaimed retinal specialist, but as a result, I get very little time with him during annual visits. Comparatively, my case is not severe as others. Do you have any recommendations on how to maximize my time during short visits?"
That's a great question. And I get this a lot, especially in this current healthcare system. I think going in with questions that you really want answered, it keeps the flow of the clinical visit, and it keeps focus on what you're most concerned about. Your physician will communicate what he's most concerned or not concerned about. But I think having an idea of how and what questions you really want answered is really to kind of make sure that you get in. It's like, okay, I have a few questions that I would like answered, and really, making sure that you make that known before he or she walks away. Because we have an agenda from a medical perspective as to what we're looking for, what are we concerned about, what are we not, and that may not be the agenda that you are, concerned about, or the symptoms that you're concerned about. So I think really making it known right as they're talking, like, oh, by the way, I have some questions. I'd really like to, get these answers. I think it really helps set the tone so the doctor knows to kind of adjust those questions before they leave.
Thank you. We're actually going to move forward. So I do see maybe a few more questions, but we will have plenty of time after each of our panelists have a time to speak to answer those questions. So we will return to those questions. Do not worry. Next, we'll have Brenda. Well, you are up, and Brenda Nikko will speak to how she's addressed the conversation of clinical trials with her physician and any other relevant points that you'd like to bring up, Brenda. So the floor is yours.
All right. Well, I'm honored to be here with everybody today. As mentioned, my name is Brenda Nikko, and I live in Fort Wayne, Indiana. I am at least I would say it. There's a strong family history of retinitis pigmentosa in my family. So growing up, I knew my great-grandfather had very little vision. That just was something that I got accustomed to very quickly. And then my dad also developed worsening symptoms over his life. When my parents decided to have children, they knew that there was a risk there, but because it had been male dominant in the family, they thought that we had kind of squeaked by. In my younger years, I realized that I did not see well in the dark and began wearing glasses at age 2. So my assumption just was that anybody who wore glasses just couldn't see well in the dark. I was monitored over, my younger years. It wasn't until I was in my 30s, and I hit a curb driving home at night that I realized that I should probably get this checked out again. So I scheduled an appointment with an ophthalmologist here in town who, while being very kind, was very blunt and told me that I did have retinitis pigmentosa and handed me a list of local resources. The first one listed was the League for the Blind and Disabled. So he basically handed me the list, but didn't tell me what each of these organizations did. So I was a little bit traumatized. It took me some time to go home and process. I wasn't sure exactly what to do with that or what questions to ask. So I kind of just dealt with it myself. Went through a period of kind of mourning and loss and unsure of what the future held. Fortunately, I was able to get involved with the Foundation Fighting Blindness, and that became a huge resource. Through their resources and my participation, I learned what questions to ask. I got connected with those organizations and also then learned about genetic testing, clinical trials. I got connected with a low vision specialist here in Fort Wayne. They completed my genetic testing, and my gene was identified as X-linked RPGR. So while there had been a strong male pattern history there, I said I apparently am an anomaly. The doctor, when she reviewed my results with me, said only 10% of our cases are X-linked RPGR, and only 10% of that 10% are female. So I said, I've always said I just like to shake things up a little bit. But through that education and that genetic testing, I was able to share that link with my family members so that they could also complete that test to determine not only for themselves, but future generations, the risk factors. Being a part of the Foundation Fighting Blindness, I learned about my retina tracker and the possibility of clinical trials. Earlier this year, I was on LinkedIn, of all places, and came across a clinical trial. This trial is conducted by Ocugen. And so I did some research and I reached out to the retina specialist here in town. He was also very heavily involved with our local chapter of the Foundation Fighting Blindness. And I said, "Hey, Doc, are you familiar with this?" Because he stays up on all the new developments. And he said, we're in the third stage of the clinical trial. If you get the opportunity, I would do it. So I began earlier this year traveling. I traveled to Dallas for my exams. And then I also complete a low-level light navigation, kind of an obstacle course to measure. But this trial was different because it is what they say gene agnostic. So it's not specific to just X-linked RPGR. They're trying to see how it's working across a broad platform or broad array, I'm sorry, of genetic conditions. So very excited. I will share, I ended up being in the control group. So that was a little bit disappointing, but I realized that I am helping further the science by going through these steps, and then we'll receive the treatment once the study is complete. So that, I can't stress enough the importance of the resources through the Foundation Fighting Blindness. If you get a diagnosis, they're a good place to start. Study what they have available and have those questions ready. If you receive a diagnosis, your next visit, I know some doctors aren't always available when you need them, but just being prepared for that next visit is crucial. Knowing what questions to ask, and then knowing what your local resources are. So, funny part of the story is the League for the Blind and Disabled, which my doctor referred me to. I am now an employee there. So, it kind of came full circle. And the League is a center for independent living that works with people with all disabilities, but it began as an organization for those who are blind and low vision. It began with seed money raised by Helen Keller, and we provide, adaptive equipment, independent living skills, and the biggest, what I think is most important, is peer support. So, getting connected with others who, it may not be the exact same cause of vision loss, but a lot of times the challenges are the same. So, building those networks with others, you learn from them, they learn from you, and just having a good support system too.
All right. Thank you, Brenda. And let me just throw, I guess, a question just to foot stomp everything you said. Just I'll throw one question out there. Um, as someone who is a part of the clinical trial process, I guess, could you dig a little bit deeper into what questions you would recommend patients bring to the eye care professionals before enrolling? Was there a particular question that you asked, or there was something that you learned that you would ask, but like maybe the major question that you would ask before enrolling in a clinical trial?
So, yeah. My first priority was safety. I wanted to know that they had gotten through a lot of the more risky, what the potential side effects are, and just knowing your risk factors for sure. Um, I, when I asked the retinal specialist, I wanted to know, I didn't want to jeopardize the vision that I do have. I have about 8 degrees of peripheral vision. And so my questions were, obviously those risk factors. What is the potential for improvement or at least stabilization? If it would prevent any further loss of vision, I would consider that a win. If I got improvement, that would just be icing on the cake. So, um, you want to know what demographics, if you're the right demographic to participate. Most of the things when I was researching were involving males. So when I came across this study, I just looked up the contact information and emailed them and said, "Hey, look, I'm a 54-year-old female. This is my gene. Am I a potential candidate?" So, um, be bold, reach out, um, and make sure that, you can, through clinicaltrials.gov has a lot of good information about the study itself in depth. And then again, having that conversation with your retina specialist, your low vision specialist, your regular eye care doctor, you know, just ask as many questions as you can.
Thank you. I'll take a quick second to make a little plug. So you mentioning all those things is basically, it's like basically seek resources, leverage resources, use the resources that are out there available to get you more informed and engaged in your journey. One
Mhm.
thing I want to make a quick plug for, in addition to what I've already mentioned in the open access genetic testing program, is also the Foundation Fighting Blindness My Retina Checker Registry, which is a research database of people and families affected by rare inherited retinal degenerative diseases. The registry is designed to share de-identified information with the IRD research and clinical communities about people with IRDs and to help accelerate the discovery of treatments and cures. So really what this registry does is, if you volunteer your information and you as a patient or a patient advocate, you're in control of this data and where it goes and who you share it with. But what it really helps you do is make that connection between between your condition and clinical trials or the companies or researchers in which are trying to study potential treatments and cures for your particular disease indication. So this is completely voluntary. And if people are interested in signing up, the information is available at our website under sort of fightingblindness.org/ my retina tracker registry. You also can email coordinator at myretinatracker.org as well. Brenda, we do have a few more questions for you. Um, we have a question here is, Brenda, has your connection with the league helped you with your trial process? It sounds like your process was handled by you on your own. So everyone out there can do the same. So how'd you handle it?
Yeah, you are your best advocate. I will say that. So, um, the league provides more of those independent living skills and learning how to do things with vision loss. I had to be proactive in seeking out potential resources. I My job at the league is information and referral coordinator. So it's my job to either connect people with the resources in our agency or connect them with community resources. So I spend a lot of time Googling things. And so I get off on a tangent and just start researching. Look at if whatever your condition is, target that in a search, and then make sure that you are getting verified resources for sure. Um, I hope I answered the question.
Yeah,
Ned, can I chime in this
sure,
as well? I
please,
think this is a really important point that Brenda's bringing up.
please go ahead, please.
So I think going to reputable resources is really important because this is a very booming field right now. 20 years ago, 30 years ago, we wouldn't be having these conversations about, oh, maybe this trial and that trial, it's sort of, it was a lot less. So I think it's really critical where you get your information. I tell parents, especially, I was like, I think this, say your kid has retinitis pigmentosa, please don't go the Google rabbit hole. Let us get more information before, things sort of unravel, because there's so much you can find online that may or may not be applicable to you and your condition, especially in the early stages as we are trying to figure out exactly what's going on with your vision. So I think knowing which sources to go to is really critical. The other thing that I tell my patients, which again, Brenda sort of alluded to, is there are a lot of clinical trials. Not all of them are appropriate for you, and not all of them are great. So let your retina specialists be those gatekeepers, because there's so much going on. I basically tell my patients, if I don't reach out to you with a clinical trial that I think you would be interested in or qualify for, and you are interested in, let me look into it. Tell me what it is. Let me look into it and see if it's something that first you qualify for with just the basics of, what they're looking for. And is it worth your time? Or is it, what? I'm not liking this science. I think you should stay away from this clinical trial. So I think you should let your retina specialist really guide you through the many options and really know what resources to look at, because again, this field is absolutely booming, and the number of horror stories from across the world and even here with inappropriate patient selection, I think it's really crucial, because we are so desperate to get any kind of improvement or slowing down that I think if we don't pause, as Brenda said, you can lose the little vision that you have. And that's really what we're trying to prevent at all costs, even though we want everybody to kind of improve science.
Sure. And Dr. Rahmani, I have a follow-up question for you. And I was going to leave it to the sort of Q&A session, but I think it's very germane to what we're talking about here. Someone in the chat has asked, do you see any issues with optometrists conducting medical tests for monitoring RP? I have been to a retina specialist, but they're very busy, and I feel more comfortable with my optometrist, who has helped me immensely with optimizing my vision via special glasses and suggestions. So I would just love your reaction to that.
Absolutely. So I think optometrists play an integral part in really getting your daily needs met. A retina specialist will not be able to give you those glasses. They'll be able to follow the medical aspect of your disease, but not what you really need on a daily basis. So I always partner with my low vision specialists. Most of them are optometrists, actually. And we work as a team because I can't provide what they can provide, and they leave the sort of the diagnosis and the medical aspect to me, and really both parts are integral. So I think optometrists play a huge role, but I do think that optometrists who have a little bit extra training in low vision will go a long way. I don't think every optometrist knows how to help Stargardt patients and RV patients, because there's a lot of specialized nuances that goes into those glasses, those tints. All those things make a huge difference. So you want to go to a specialist that can help you with that. And big centers that have retina specialists really have a network of referral just for that very reason, because it takes specialized training to be able to help. But absolutely, this is a team sport. One physician and one provider is not going to be able to meet all your needs, definitely. Great question.
All right, we have another panelist who has just been able to join us, and we have Jamie Cutler. So, Jamie, if you could maybe come off mute, and if you're able to come on the screen as well. But Jamie Cutler is a dedicated advocate and parent to a son with LCA5. As chapter president of the Foundation Fighting Blindness Chicago chapter, Jamie shares a wealth of personal experience in seeking treatment and navigating the patient journey. I heard Jamie speak at the recent Night for Sight, gala in Chicago, and was just really motivated by what Jamie shared. So, Jamie, thank you so much for being with us this afternoon. And please, your opening remarks.
Thank you so much. I really appreciate it. And I will try and get on camera in just a moment. We've had quite a day over here in the Cutler house. I'm out and about, but I am so happy to be a part of this. This is something that I feel so strongly about, and I've been so interested in all the information shared by all of our panelists and all of the great questions that have been asked. Our journey started 5 years ago in May of 2020. Ari, my son, is 5 years old. And he was born just at the height of COVID. And my husband and I had done all of the panels for genetic testing. My background's in social work, and I just wanted to go in knowledgeable and able to just be able to meet my child wherever they were in their journey. And we had no indicator that anything was going on with Ari's eyes. And right after we brought him home, I noticed right away that he had nystagmus. I noticed that his eyes did a beautiful dance. And I also noticed that he was never looking at me. He wasn't looking at objects. He would only find the brightest light in the room and focus on that. And I immediately, he is my second child. So my daughter, Nora, who is sighted, she was the reason that I even knew to question, because had Ari been my first, I probably just would have assumed for a long time that maybe the eyes were underdeveloped. But I ended up going to Ari's pediatrician, and within the first week of his life, and saying, I just don't see a connection. I can't see him focusing on me. And I was told, the eyes take longer to develop, rightfully so. And that we just needed to give him time. And I knew by 8 weeks old that Ari could not see me. There was just no identifiers other than looking up at bright lights. So from there, we embarked on a year-long journey of trying to figure out what it was that was facing Ari with his eyes. They assumed maybe it was a stroke in utero. He had an MRI at 6 months, a brain MRI, and and then they thought maybe that he just didn't have great vision, and they fitted him for glasses as an infant. And today Ari does wear glasses. It's more so for protection, and also with the LCA5 diagnosis, there's a lot of pressing that goes on, so pushing on the eyes. And so he wears glasses also to protect from that. But they're about as farsighted as you can be, and we are hoping that they provide him with maybe the tiniest bit of vision to enhance it. But so within that year, we had seen, I can't even tell you how many ophthalmologists, how many doctors we had asked about his eyes. And I would go in and just say over and over again that he would just be pressing all day, pushing on his eyes. And I didn't know what it was. And I, would Google and see all of these different things, but I could not pinpoint what it was that he was doing when he would press and push. And the ophthalmologist that we were seeing at the time did not know either. So they had assumed, because we did the genetic testing, that there was nothing else to look out for genetically in terms of there being any sort of, retinal, any sort of issue with the retina. and beyond. And then finally, when I went back to the drawing board, I started asking friends and family if any of them had any sort of relationship to an eye disorder. We ended up finding out that Jordan, my husband's sister, had tested on a new prenatal test. So this was more than a year, almost a year later, that she had done an extra panel on herself. So not on a child, just on herself. And LCA5 was something that came up in her genetic panel. So that led us to go back to our ophthalmologist and inquire about LCA5. And we were told that only an ERG could determine it. Unfortunately, due to COVID, the ERG was not operating in Lurie's for almost a year. And at 1 year old, when Ari did do the ERG, we were able to correctly diagnose him with LCA5. So that was the beginning of Ari's life in terms of finding out a diagnosis. And because of COVID, I think that many of our avenues were skewed a little bit. I don't think the experience would be the same today, but I also know that there's a lot more out there today, 5 years later. The only thing that I could rely on truly was when I Google searched blindness, when I could really tell that Ari wasn't seeing and we didn't have a diagnosis yet. And the two things that came up for me were Chicago Lighthouse and Foundation Fighting Blindness, just from a simple Google search. But I started by Google searching blindness Chicago, and I was taken to Chicago Lighthouse, where we met Marla Gartzka, who did Ari's early intervention. And she led us to the Brints, to David and Betsy Brint, who happened to live one city over from us, and their son shares the same diagnosis as Ari. So Ari's diagnosis, LCA5, is 1 in 1.7 million. And we have somebody who lives less than a city away, just right down the block from us, with the same diagnosis. So to say that it was meant to be is an understatement, but they, of course, led us to Foundation Fighting Blindness, and it's been a wonderful relationship ever since. So that's my story with Ari. My background with FFB is just learning more about I's diagnosis, which I learned everything about LCA5, not from our ophthalmologist, unfortunately. Now we are with a different ophthalmologist who I met through one of the FFB events. And so that has been one of the many ways that I've been able to advance my understanding of LCA5 through FFB. But in terms of connecting with people who could give me, insight, FFB has really been my go-to through and through. And now, thankfully, with our new ophthalmology center, which includes Dr. Rahmani. So we see Dr. Rahmani's partner, Dr. Rawson, and I approached them awkwardly at a kickoff for the vision walk, and just said, "You two are my heroes. How can we see you?" And so that's what led us to them. And now we are very much in talks for hopefully Ari to be a part of the LCA5 trial at the University of Pennsylvania, at the Children's Hospital of Philadelphia. There is an LCA5 trial happening right now they've already done 3 adults and 3 adolescents. And the hope is, if there's an infancy stage, that Ari can be a part of it. And if not, we hope that it's one day FDA approved, and that maybe we can even go to Lurie's downtown and benefit from having his surgery done close to home. But we went to Philadelphia last year for the first time, and we'll be returning in January. So there are just so many wonderful things to come from this relationship with FFB, including being the chapter president, including being able to advocate for my son and advocate for others in the community. And now that he's in a public elementary school, I'm advocating more than I ever thought, and I just couldn't do it without FFB's support. So I'm happy to answer any questions. My experience with talking to my clinicians, it was harder. People don't know what they don't know, and LCA5 being so incredibly rare, it really wasn't on anybody's radar, just because of our genetic testing panel. But I hate that it stopped there. I hate that the assumption was that because there was nothing on that panel that showed up, that we shouldn't question more. And I never knew to question more, because I was like everyone else, thinking, well, if it didn't show up, then there's nothing to worry about. But obviously we know that's not the case. There are 1 in a millions out there, and there's some, even less than that. But the important thing is just that we're all able to ask the hard questions and to advocate for ourselves. And I encourage everyone on the call to do that.
Jamie, thank you so much. Just from hearing you, we can sense and feel the passion that you have for making sure that we are collectively driving towards a treatment cure for these blinding disorders. I do have a follow-up question for you that maybe can give a little bit more details for the audience here,
Mhm.
and really about. I have two questions for you. So one is, what advice would you give to other parents or caregivers on balancing hope and realistic expectations when discussing possible future therapies or trials with doctors?
That is a very good question. I can tell you from personal experience, we had, and this sounds so heartbreaking now, 5 years later, but hearing Ari's diagnosis with LCA5 and that he had not only a severe vision loss, but that he would lose the rest of his vision in his older years. So whatever it is that he did have, it would be his best and then it would be lost. We weren't given very much hope in the beginning about a trial, a treatment. It was more so, here are the cards that you've been dealt and now let's push forward. So we went that route. We went the, we've all started learning Braille. He uses a cane. He is a cane user. We were living life as if there wasn't anything out there. And then something was brought to us through the Brints, letting us know that there was something there. But I would say always have hope. I mean, the world is changing, but more than anything, FFB is evolving with over 50 trials. I would say always keep hope and at the same time embrace the resources that are in front of you and don't stop fighting for things. Ari's in a public elementary school right now, a mainstream elementary school with all sighted kids, and they're offering him phenomenal resources. But I find all the time that I am asking for things or recommending things that nobody would think of if they are sighted and not used to learning differently. So the way that things are being adapted for him, etc., that all has to come from word of mouth. And again, my background being in social work, I was used to advocating for other people, but I just want to encourage everyone. If you have questions, if you have concerns, if you have hopes, just keep pushing until you find the right person. And by sticking with FFB, a lot of those questions regarding the eyes will hopefully be answered. Don't be afraid to reach out to your community manager. Reach out to me. I don't have many answers, but I know people who do. So I can bounce it off to other people, but I just think that knowledge is power, and being in a powerless place for a long time with this just showed me how important it is for everyone to seek whatever it is that they're wondering.
And we do have a question from the audience that you might be able to address, James. So I'll just throw it out there, but please, other panelists as well. The question is, my adult son has Stargardt's. His retinal specialist is quite passive about low vision resources in clinical trials. How can I support a more proactive approach and still respect his adultness?
It's a very good question. I think that the important thing is that if you're dealing with somebody who's passive and that is not your personality to meet them where they are, if you are searching for more, then you have to go and find more. And what I would recommend doing is connecting with FFB and finding out what resources are available for Stargardt's, what trials are out there, what doctors are doing the research to figure out next steps. And I would see if you could connect with somebody from there. And a good ophthalmologist, a good eye doctor will always support finding more insight. It's not you leaving them behind, but instead it's just trying to continue on that journey and make them a part of it. Let them know, I found somebody who studies this specifically in this location, and just see if you can connect. See if they would do a phone conversation, or even connecting with their front office staff. You'd be amazed how filled in everybody is in this space.
Brenda, would you like to maybe speak to that at all as well?
Sure. I understand the perspective there. The Center for Independent Living promotes independence of the consumer and is very consumer driven. So I get that all the time. I get well-meaning family members wanting information, which I will gladly share. But the way our premise is, we can't do anything without that consumer initiating the process. Um, I have a family member that's in the same position, doesn't really want to address things, and you have to allow them the space to process while still supporting them with the information. So sometimes it's all about the approach and the way that you present it to them, as, understand this is difficult. Here's something that can offer you hope. But in the end, it's going to have to be his decision to either proceed or learn how to adapt.
All right. Well, thank you all for your comments and sharing each of your individual stories and your connection with the low vision and blindness community. Now I will open up the floor for our Q&A session. So we have two questions. I guess will be currently focused, I believe, for you, Dr. Rahmani, that you might be able to address. I'm still looking around all my different screens to try to capture all the questions and comments. So please bear with me. But the first question is, if a treatment is available, my doctor may not be able to prescribe due to approval in Medicare or their formulary. How can I get an approved medication if my doctor will not prescribe? Do I just go and find another doctor? So, Dr. Rahmani?
In the eye space, there's not that many treatment plans that are, I think will not eventually get covered, because the doctor can write it and then it's really going through the authorization process through the insurance. So if one doctor can't do it, doesn't mean the other doctor can. It mostly is a logistics problem. So for example, Luxturna is a very common, question that I get, like, how does that happen? Like, we have a whole team that allow us to get clearance for the patient to get it cleared to get the treatment. So if the treatment is appropriate and your doctor wants to give you that treatment, but they can't because of the insurance logistics, there's many avenues in terms of prior authorizations and other connections that we can get clearance for. Right now, I think Luxturna is really what comes to my mind, but I don't think going to different doctors is going to help unless the doctors, doesn't think that that particular therapy will help you, and you can get a second opinion from another doctor.
All right. Thank you. Brenda, you had mentioned about mental health in general, and someone in the chat, Angela Tab, mentioned that FFB does have a resource that is focused on people with low vision, and it's the Mental Health Resource Center. So again, that's fightingblindness.org/mental-health, where people can find more resources for mental health, whether it be you as a patient or even as a caregiver for somebody with low vision. That the foundation does have resources that deal with mental health for people with low vision. So just wanted to share that with the group. Also, to that point, and I keep giving out resources and stuff, so please bear with me. These are plugs for resources that the foundation can actually help with. The mentioning of basically finding more accessibility tools or even a broader community. I did want to mention that the Foundation Fighting Blindness, in partner with Retina International World Congress, will be holding our United in Vision conference this coming June 12th and 13th, 2026 in Texas. And the attendees will be exploring cutting edge advancements in research, emerging therapies and innovations in assistive technologies, products, and services. The sessions are led by globally recognized experts and advocates, and will address solutions to improve treatment access and enhance quality of life for individuals affected by blinding conditions. So I just wanted to make that if people on this call are looking or maybe having trouble finding resources or finding a community, that if you have the ability to attend this United in Vision conference, which again will be held in June of this coming year in Fort Worth, Texas. It's a great event, and I just encourage everyone to attend. All right, we have another question, and Dr. Rahmani, I have to throw this question over to you because I am not aware of clinical trials in this area, but there was a question that asked, are there any known clinical trials for familial exudative retinopathy, or FEVR currently?
There's currently no good trials out for FEVR. I know a lot of people are working on it, but there are no good trials for FEVR. Lots of good treatments, but no good trials right now to try to prevent it.
Fantastic. Thank you for that answer. The next question is, I am 51 years old and was diagnosed with RP at 13. I've been going to several retinal specialists for 35 years. I have had 3 whole genome tests completed. I've been told recently I have a mutation that is not known and could be RP, but not known at this time. Do you have any advice on what I should look to do next?
I think this really points out to the field of genetic testing and where we are. It is moving so rapidly, and we're finding new genes all the time. I think while we wait to try to figure out, is this the gene that is affecting and really causing the retinitis pigmentosa, I think really focusing on getting all the resources you need to be able to do everything you need is really more important. And I basically test my patients who are unknown or suspicious every few years because the field is moving so rapidly. So I have a whole list of people that I'm like, this looks like a suspicious gene that popped up. This was negative. Every 2 to 3 years, because so many genes are added on a regular basis, I retest the patient. So if your last test was in the past, 2 to 3 years, I wouldn't retest again. I would just wait, another year or so, and potentially go down that road. But at this point, a lot of the clinical trials are with, very well understood, genes and mechanisms. So it would be much more beneficial to spend time focusing on how to, use the vision that you have, and also potentially looking into gene agnostic or gene independent trials that may be interested, because it sounds like you've had a wonderful complete workup multiple times over. So, and we're not good enough to find all the genes yet. We think so, but we're not. Every time, like we still are learning so much about these diseases and why it's so different and different. Brenda mentioned it. Why is she the 10% of the 10%? We don't have so much information that we still think we need to understand. We don't. So I think at this juncture, if you've had this great workup, I would say focus on using the vision that you have to the best that you can, and then looking to trials that have nothing to do with genes, because at this point, that's not going to change what we do for you.
Right. So, Dr. Rahmani, I want to stay on this point just a little bit more, because I think that for our audience, it might be important to know that there are sort of different buckets of sort of therapy categories per se. So, really, what's driving our field right now, I believe, would be in maybe 3 different buckets. And what one would I would say would be probably agnostic therapies, which no matter the underlying genetic driver of your disease, these agnostic therapies are really at this point in time geared to slow the progression of the disease. Then we also have what I would say genetic technologies, and that would be in the bucket of classical gene therapy, which I think has been sort of most known in the news right now, where you're taking, if someone has a defective gene, you're giving them the working gene that will produce the protein in order to now restore function in the eye. Or what has really been exciting is genetic editing, where people can actually give a drug that actually will go in and do some sort of precision editing of the DNA and actually be able to restore function. And then third, we have sort of restorative medicines or restorative therapies, which would be the bucket of like stem cell therapy, where if you actually have a damaged retina where either certain cell type in your eye is lost, so the removal of the photoreceptors, to actually be able to give that a stem cell back to that person, and then that stem cell would then transform into a working photoreceptor or whatever other cell type needed to restore vision. So could you, even though I've sort of outlined that, if there's any additional sort of information you give to people about when they're looking at clinical trials and for things that maybe aren't available, even if you don't know your genetic driver, that there also is emerging therapies that may work for them as well.
Of course, no, I think you covered it really well. This field is it can be generalized, but it can also be really nuanced. So I think it really depends on at what point the genetic mutation or the disease is caught, and then what is available that can sort of proceed forward. So for example, if someone's had issues for 20 years and they have significant vision loss, they may not even qualify for some of the trials that are looking to preserve the cells that are still there. So you kind of have to look at it at a timeline where we have cells that are healthy-ish working. Then you got sort of the middle bucket where you got unhealthy cells that are still, working, but they need a lot of help. And then you have the sort of the cells that are gone. So those three big buckets that you talked about really fit into those. Where are you in the continuum of your disease process? And how fast is your disease process? So LCA5 behaves very differently than, other RP genes and other LCA genes. So that really can dictate which bucket you should even sort of think about. I think the easy kind of way to think about sort of buckets is if it's gene agnostic, I think there's a few trials looking at oral supplements and potential treatments. Those you can think of as sort of supporting the cells that are already there. So potentially they could be less side effects because most of them don't require surgery and don't require, sort of going through down that route. The middle bucket, which is really what our main focus has been for a long time, is gene therapy and gene augmentation, which you pointed out, whether to give the gene back versus not, or supplementing. That, I think, is the biggest exciting fact, but it requires surgery. It requires a lot of unknown things that we have to account for. And, we make it sound, oh, just cut the gene and give the new one back. Like it is, Luxturna, it took 15 years of work to get to where it is. This is not, we're talking about neural tissue. We're talking about brain tissue. So these are incredibly complex systems for us to try to recapitulate, which really brings me down to stem cells. Stem cells are sort of right now, I think, is sort of behind with all the other clinical trials in terms of how far they're getting, not because not because we're not trying, is because the system's incredibly complex. So if the cells are not working, the cells don't stay there stagnant. They kind of shift around and they reconnect to all sorts of other cells. So when you're giving stem cells back, that's not the system that was there, say, 20 years ago. So there's so many nuances that we have to be able to control and figure out. And that's why, I think in the field right now, the two other buckets are moving quickly and stem cells are a little bit behind. But again, not that because we're not trying, but it's because it is incredibly complicated to be able to restore things that are really meaningful, because we can restore the cells, but is it meaningful to the patient and the function? That I think is a whole different bucket.
Okay. And Dr. Rahmani, I have one more question to you, but I just want to warn Brenda and James, I'm coming to you next, so get ready. And I just want to, again, foot stomp the point about stem cells. So I think probably over the last, let's just call it 10 years, we've seen a lot of sort of these maybe shopping mall, strip mall type clinics saying, hey, we can use your own stem cells to cure your vision. And we have seen, and these things have not been in clinical trials. These are sort of fly-by-night, I don't even want to call them clinics. I don't even know what to call them. These are fly-by-night shops that are offering cures to people without any evidence. So I just want for the audience here for you to speak to that a little bit and maybe give them some insights onto what differentiates a true clinical trial versus someone sitting in a shop claiming to be able to use your own stem cells from your blood to be able to cure vision.
What a great question. I want to say this very firmly. There's no stem cell therapy or anything right now at this juncture that can do that. We cannot take your stem cells and restore your vision. And the reason why these shops keep popping up everywhere is because they're really banking on the desperation of our patients to give them any kind of, potential. And stem cells sounds really nice because we do use stem cell therapy for a multitude of other ways to help other body parts. It's sort of standard practice in many, many other body parts, but not the eyes. So that's a very specific thing that I think people kind of get lulled, like, oh, well, there's stem cells for 5 other organs and systems of the body. Why not the eyes? The eyes, the brain. And that's why at this juncture, I would never recommend a stem cell therapy in these systems where they're kind of plugging that cure. If it was that easy, then all the hospitals and all the clinics that they are going to would offer it. If it's not, then you really have to, have these warning bells, off, mayday errors going off. And I can give you a very specific example. It doesn't have to do with with inherited retinal degeneration. It has to do with macular degeneration, but this actually happened where people got stem cells in their eyes trying to get treatment for macular degeneration, and they had horrible outcomes. And this is all published. This is nothing, and those people out of desperate, they were taken advantage of, really, in my opinion, out of desperation of getting any kind of vision back. And they lost the vision that they had, and catastrophic, consequences. So this is the reason why, we tell patients, please let your doctors be your gatekeepers in terms of what you want to go into or not. If it's in a mall and the regular offices are not offering it, really question how are they able to offer this, and really question, where's this coming from? Because if it was that easy, then you bet that all the other ophthalmologists would be signing up for it and giving you that treatment.
Thank you so much. And now I'm going to pivot back a little bit about the experience of talking with your physician. So, Jamie, I wanted to throw a question your way. And what are the biggest barriers from both, I guess, the patient and caregiver side in talking with your physician and effectively communicating your position, your understanding, and then them also communicating with you? So, what do you think some of those biggest barriers are, and maybe how can one go about maybe breaking down some of those barriers?
I think that my biggest lessons came from things that I would do differently in the future. So it was less about the correspondence actually that occurred. It was more about what I wished I had done differently moving forward with it. So, for example, when our initial ophthalmologist long ago was telling us that Ari would need an ERG in order to determine once and for all if it were LCA5, it was worded to us that it was a very non-invasive, very easy test. And he was under 1 year old. And so the assumption that we were led to believe was that this was something that we could walk in and it would be very quick and it would not bother Ari and he could be wide awake. And Jordan and I went completely, we did not know. And the ERG was actually quite intense for Ari, and it took a very long time, and he cried until he threw up, and there were so many things, and I wasn't allowed to go in, and it created a lot of trauma that I think could have been avoided if more research, well, not even research, but if more resources were in place about these types of testing. So on a broader scale, I would say to not accept the bare minimum from any information that you're given, even despite the confidence of it. Again, if you are with somebody long-term, a physician that you trust, and you feel like you are knowledgeable of the next steps, that's one thing. But if you have any questions or you feel like you're in the dark at all about information that's being provided to you, I encourage you and urge you to do more than I did. I'm not a social media person, but I know that that can be a great tool for connecting with other people, finding out more about what their experience was with a certain thing, whether it be a trial, whether it be a test that you have to take, or whether it just be trying to understand more about maybe some news that you were given. I always go back to the idea that knowledge is power. And I think a lot of the traumatic experiences that Jordan and I had with trying to learn more about Ari's diagnosis, all of the doctor's appointments that he had, the things that we learned later. And not to take up too much time, but for example, we learned down the road, actually from Betsy and David, that something that their child did not enjoy growing up was having the drops put into their eyes, because the dilating drops do actually sting at times. That's something somebody like me who never even wore glasses, I think I've maybe had one eye test my whole life. It was something I was unfamiliar with, but it became a bargaining chip now for Ari, because it turned out Ari, who does not have the words to tell me that necessarily, it turned out that those dilation drops really do bother him too. And to have to take him so often just to have his eyes reevaluated, we began advocating for the fact that maybe we could skip over the dilations and limit the amount of times that they're done. So, needless to say, again, I would not accept the bare minimum of any conversation that you have, or if you're left with any questions, find more resources.
Brenda, same question to you.
Yeah, I would agree. I am I always had a little bit of a inferiority complex and um felt like, okay, I accepted what doctors told me, not just necessarily vision related, but in most scenarios. So I didn't question what was told to me, but I became more empowered after getting connected with the Foundation Fighting Blindness and learned that I could ask those questions and that sometimes doctors were infallible. I mean, that they could not have all the answers. So, um, for me, finding my low vision specialist went above and beyond just what my ophthalmologist available was crucial. Uh, the retinal specialist that I did see, he is wonderful. He shared, and I don't have statistics to prove this was true, but he had shared that at one point, um, the suicide rate for eye care professionals was so much higher because they felt at a loss because they felt like there was nothing available for their patients. So, now with these new developments, I think that they're sharing better information that's available and offering hope for their patients.
Thank you. We are getting probably short on time. So what I wanted to do was offer each panelist just maybe if you give some brief closing remarks for our audience today, maybe a take-home message that you would send them with, please. Jamie, would you like to start?
I think my take home message would be that you should surround yourself with people who lift you up, whether it be within FFB, which I have to tell you has been an unbelievable resource for us. But I found that even at the beginning of Ari's diagnosis, I'd always instructed people long before Ari to access support groups, and I think that they are vital. However, I learned that the right support group for me was very different than what was maybe for my peer. For somebody who wanted answers, I found more comfort in reaching out to families or support groups where older people had already crossed a lot of the paths that I had not gotten to yet. And it was helpful to, instead of connecting with people who were in the same boat as me and kind of, creating a camaraderie over some of the grieving process, I found it more enticing to reach out to those who had already surpassed the stage that I was in, just to provide some next steps, whether it be something I can look forward to, something I should watch out for. So I encourage everybody to do that. Find a resource that suits you and stick by it, and just continue to search for that light at the end of the tunnel, because FFB is searching every day for it, and you have a great support system behind you. We're all a part of the same village. So anything I can do to support anybody, I'm really honored to be a part of your journey.
Thank you, Tammy. Brenda?
I would say, I don't think that we are given our challenges just for our own personal growth. I think that our experiences and our perspectives can help someone else in their struggles. So again, as everybody said, just getting connected with the right resources, um, and you are your best advocate. Nobody knows the challenges you face. So be bold and speak up and ask those hard questions. And if you're not satisfied with the answer you get, keep going until you have a good understanding.
Thank you. And Dr. Rahmani?
I mean, Brenda and Jamie sort of covered it all, but I think from a physician perspective, I think it's important to not get frustrated if you have to see multiple eye professionals before you get an answer and before you have a team that you can trust. FFB seems like a big, area to, really bring everybody together, but these are incredibly rare diseases. Most eye professionals will never see these in their training or even sometimes career. So I think the biggest thing that I get, because I'm usually the fourth or the fifth doctor that they're coming to, is frustration. Like, how could this not have been diagnosed, you know, with the first doctor, you know? And as I think one of the panelists said, like, what they don't know what they don't know, because these are so incredibly rare. So don't think that the eye doctors are not trying to help you. And it's not surprising if you need to have a team of eye care professionals, like I said, a retina specialist for the medicine, low vision specialist, you know, all these teams that go into it. Kind of, you need to build a community, and it will take time to build that community of people that you trust and can go into. It's not going to be instant. I think because of where FFB is and the resources that they have, it's wonderful start. You know, I think that I refer my patients to FFB, and like, please get started. In one short visit, I can't give you all the resources. There's so many questions that are going to come up, which I thought I would answer, but we didn't get a chance to, or it wasn't processed, because it is so, you know, can be so life altering. So don't be frustrated. These are very rare diseases, and expect to have a team of eye doctors that are caring for you, because that's how you get the best care, because everybody has their own niche that they can help you.
Thank you. And before I throw it back over to Bailey, I just want to mention to everyone here that the FFB is a great organization for resources. Today on the call, we've mentioned our open access genetic testing program, in which people who don't know the genetic diagnosis yet can access for free through their retinal specialist, who can order that testing for them. Two would be also the voluntary participation in our My Retina Tracker registry, which your genetic information will be used to put you in touch with people who are conducting clinical trials that you may want to participate in. So also consider that. And then lastly, which Bailey will mention more about, is our United Envisions conference is happening in 2026. As our CEO, Jason Menzo, says to our internal team, we have this thing called OTOD, which stands for One Team, One Dream. And our dream is to eradicate blinding disorders. And as you see, Vivant, we're all in this together. So reach out to us, engage, hold us accountable, and we will all strive to end these blinding disorders. So thank you for your time, and thank you, panelists, for taking time out of your day to share your perspectives. We really appreciate it. Bailey?
Wonderful. Thank you so much, Chad. And once again, thank you to all our fantastic panelists that we have here today. I'd also love to take a moment and thank our sponsors who help us make things like this happen. They are fantastic and you know, help keep the wheels turning. And like Chad mentioned, if you enjoyed our chat today, please make sure that you mark your calendar for June 12th and 13th for our United Envisions conference in Fort Worth, Texas. So this is a premier event that brings together individuals and families impacted by blinding retinal conditions, alongside of leading researchers and clinicians, to foster collaboration, innovation, and hope. So in these sessions, you will experience around the topics around the latest research advancements, science sessions, and also our sought after living and thriving sessions. If all that does not sound exciting enough, we do have our keynote speaker, Anastasia Pagonis, who's a Paralympic gold and bronze medalist and a world record holder in swimming, who is going to share her journey of resilience, advocacy, and empowerment. So please check out the entire lineup of the sessions and reserve your tickets. You can find it on our website at fightingblindness.org/visions-2026 for more information. Once again, as a reminder, in the following week, we will be sending out the recording of this session. If you enjoyed it and would like to get involved in other activities in your community, such as the Vision Walks, Vision Connections, please make sure to reach out to us. Our email address is info@fightingblindness.org. Once again, thank you to all our fantastic panelists that we have here today. We are so excited that you were able to spend some time and join us today. Enjoy your weekend and have a great day.
Thank you so much.
Bye-bye.
Take care, everyone.